Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So now we are discussing our first aid series, episode 11, that is Lumbosacral Plexus and lower extremity nerves. Myself, I am Dr. Anand Jhana. So let's go. Lumbosacral plexus, a crucial nerve network that supplies motor and sensory innervation to the lower limb. This plexus is formed by the ventral rami of the spinal nerves from L2 to L3. So let's break it down using the diagrams. If you are seeing this image, you can see here the lumbosacral plexus provides mostly the motor and sensory innervation to the lower limb and is formed by ventral rami of the L2 through S3 spinal nerves. This is first aid. So everything while I am discussing, I will highlight the main points. Okay, so here the plexus has two main divisions. If you are seeing here, that is one is posterior division and second one anterior division. In posterior division, it's mostly you can see green in color. So generally it supplies extensor muscles. Okay, so posterior division, if this green in color, this everything is supplied by extensor muscles, for example like gluteal muscle, and this green color is coding the image, help us trace which part of the plexus contributes to which nerve. Okay, next one, anterior division. The anterior division, it's that color will be like yellow color and it generally supplies to the flexor muscles, example like hip flexors, extensor hip flexors and knee extensor muscles. Okay, so the upper plexus, if you are coming here, you can divide into the lumbar plexus. We can divide into two types. Okay, two types of plexus. One is upper plexus and second one lower plexus. In upper plexus, mostly we can see lumbar portion, like from T12 to, you can see this image, from T12 and L1, L2, L3, L4. This till L4 we can see that is upper portion, and that upper portion we call upper plexus of lumbar portion. Okay, so first, if you see here, you can see here one nerve, that is iliohypogastric nerve. This iliohypogastric nerve coming from L2, this from thoracic 12th nerve and first lumbar nerve. This T12 and L1 supplies the abdominal wall muscles and skin over the gluteal region. Second one we can see here, that is ilioinguinal nerve. The ilioinguinal nerve, like originating from L1, and it innervates the skin of the groin and scrotum and labia. Okay, next one, genitofemoral nerve. The genitofemoral nerve we can see like L1 and L2. It mostly splits into genital and femoral branches. Okay, next one, lateral femoral cutaneous nerve. This lateral femoral cutaneous nerve we can see like L2 and L3. L2 and L3 is originating from there, that originating, and it forms L2 and L2 and L3, and it supplies the sensation to the lateral thigh. Okay, next one, femoral nerve. In this femoral nerve you can see here mostly L2 and L3 and L4. These four nerves will forms the femoral nerve. You can see here, this is the femoral nerve formed by L2, L3 and L4. These three nerves, main nerves, and we can see these things in posterior division. It supplies the anterior thigh muscles, example like quadriceps muscles. Okay, next one, obturator nerve. This obturator nerve is originating from L2 to L3 and L4, mostly anterior division. It supplies to the adductor muscles of the thigh. And next one, accessory obturator nerve. This accessory obturator nerve is like variably present. Okay, why we have to learn these things? What is the important means? If any person got lumbar disc herniation or sciatica, easily based on this innervation we can understand which nerve is getting compression. Okay, so which nerve getting irritation, hyperactivity, and because of that thing that patient will feel the radiating pain till like that nerve, wherever that nerve is passing, that there that patient will get pain. So that's why for understanding pathology we have to understand before the anatomy properly. So that's why I'm going to discuss this topic in very little deeply. Okay, so that's why I'm making one video for lumbosacral plexus and lower extremities innervation. Okay, now lumbosacral trunk. In lumbosacral trunk you can see like L4 and L5, like this is formed by part of like L4 and all of L5. It connects the lumbar plexus to the sacral plexus, ensuring a bridge between the two systems. Next one, lower plexus. In lower plexus we can see like from L4 to L4, L5, S1, S2, S3. These are the lower plexus we call sacral portion of the L4 to S3. The sacral plexus is formed from this is the lower this is the lower plexus, or you can call sacral portion of the lower plexus. We can see L4 to S3. Okay, the sacral plexus is formed from L4, L5, S1, S2, S3. Okay, so these are the, from here that now that plexus will give rise. So here we can see some main nerves. That is, first one, superior gluteal nerve. The superior gluteal nerve we can see from L5 to here. This is the superior gluteal nerve. It's that nerve is supplied gives rise from L4 to S1, and here it supplies the gluteal medius, gluteal minimus, and tensor fascia lata. Okay, so next one, inferior gluteal nerve. The inferior gluteal nerve, if you are seeing this nerve like plexus properly, you can see here L5 and S1 and S2 that are give rise this inferior gluteal nerve, and it supplies that nerve will supply the gluteus maximus muscle. And next one, sciatica nerve. The sciatica nerve is very important because mostly if any dislocation happens or acetabular fracture happens or any lumbar disc herniation happens in this nerves, the main nerve is sciatica nerve. The sciatica nerve will get compression because of that thing, or stretch because of that thing. We can see neuroplexia or lumbar disc herniation, sciatica pain, radiating pain. These are the things we can see in sciatica nerve. In the sciatica nerve we can see like L5 to S1 is in L4, L5, S1, S2, S3. So this every nerve is originating gives rise to sciatica nerve. The largest nerve in the body further divides into, like the sciatica nerve is divided into two divisions, like 1, 2. First one, common fibular nerve. Already we have here, sorry, common fibular nerve, and another one tibial nerve. This is coming from sciatica nerve. Okay, so this common fibular nerve mostly we can see in posterior division of the thigh. The tibial nerve we can see in anterior division, and this innervates the posterior thigh, leg, and foot. Okay, so functions, in functionally we can think like posterior division will be here. This is the posterior division. Now I am going to discuss about functions. In posterior division we can see like that nerves in green in color. We can see like femoral, common fibular, superior gluteal, and inferior gluteal muscles will get innervation. When it's coming to anterior division, the anterior division nerves will be in yellow color. We can see obturator and tibial and accessory obturators. Okay, so here now I am going to tell some clinical relevance things, like clinically important things. If you are starting the clinicals, that doctors in orthopedic or accidental emergency department they can maybe ask. So that's why I am going to discuss. If any person got injury to the femoral nerve can cause loss of knee extension, that person can't do knee extension. If any person like got like compression of lateral femoral cutaneous nerve like causes myalgia or paresthetica, like burning over the lateral thigh, okay, lateral thigh sensation we can see. If any injury happens in sciatica nerve, that patient can lead to foot drop or loss of knee flexion. If any patient got obturator nerve damage, it affects the thigh adduction, often injured in pelvic injuries. Understanding plexus division helps in nerve blocks, and we can easily block the nerve, and we can do for surgery's purpose, like example like femoral or sciatical nerve blocks during lower limb surgeries. Okay. So now when we are going to like introduction of we already discussed introduction of lumbar plexus, lumbosacral plexus, that we can do that. Mostly what I told, the lumbosacral plexus, the nerve network that innervates the lower limb, and it arises from the ventral rami of spinal nerves like L2 to S3, and is divided into two types, like two parts, lumbar plexus and sacral plexus. Lumbar plexus will be like we can see L1 to L4, sacral plexus will be L4 to L3. Okay. So now we are going to main thing, that is now we are going to discuss each and every nerve little deep, like origin and function, clinical relevance and presentation of injury. I will try to show some images also. Okay. So subcostal nerve, it's like main important nerve, that is from T12. Okay, T12 nerve we call subcostal nerve. It's like it's not in image, but clinically it's very relevant. So if in sensory, skin over like anterior suprailiac spine and hip, sensation will comes from subcostal nerve, T12. Clinically what important means, can be injured in abdominal wall surgeries. So while doing surgeries, it can injure that nerve, so that person can't feel the sensation in abdominal wall, can't feel sensation in ASIS and hip. Okay. Next, so in lower extremities nerves, first now we are going to discuss about iliohypogastric nerve. This iliohypogastric nerve originates from L2 to L1. In motor innervation we can see like internal oblique and transversus abdominis muscle. Okay. In sensory we can see suprapubic and gluteal region, suprapubic and gluteal regions like via anterior and lateral branches. Next one, causes of injury. If any patient got like abdominal or pelvic surgery, while incision like entrapment or retraction, that nerve can get traction, that nerve can get injury or tear. In presentation mostly we can see burning or tingling pain at incision site, okay, and radiating to the suprapubic region. Okay. So sometimes in appendectomy injury leads to loss of suprapubic skin sensation, okay, while doing appendectomy. Now you can see here image, here you can see subcostal nerve T12 and iliohypogastric nerve and ilioinguinal nerve and genitofemoral nerve and lateral cutaneous nerve of thigh or femoral nerve, obturator nerve. Okay. And here why this is relevant, if you are seeing here, if okay, if you are seeing here, you can see here one image. If any patient is pregnant and she have some complications for delivery, that time we will do some C-section like this. Okay. From down of the umbilicus, like below the 2 to 5 centimeters, we can do C-section. In that C-section, that time you can see here this nerves, iliohypogastric nerve and ilioinguinal nerve is passing. So we will make incision from like 2 to 10 centimeters. While doing that incision, that patient can get this iliohypogastric nerve and ilioinguinal nerve can tear, okay, while doing surgery. So that time that patient will loss of sensation. that patient will loss of sensation in that suprapubic skin region and suprapubic region, and mostly that hip and medial part of the hip, that patient will not feel the sensation. Okay, so that's why this is very important and very like sometimes we can with surgeries because of incision or retraction we can cause the injury also for this nerve. So this iliohypogastric nerve is very important now. Okay, so next one we can see here, yeah, we can see here one nerve, that is ilioinguinal nerve. This ilioinguinal nerve we can comes from originates from L1, and mostly it's like motor function same to same like iliohypogastric nerve. It assists iliohypogastric. In sensory we can see like upper medial thigh, I already mentioned the upper medial thigh and mons pubis and scrotum and labia majora. If this nerve get injury out of tear, then the patient will get not sensation in mons pubis, scrotum and labia majora. In injury during hernia repair, most commonly this nerve will get injured. In presentation, pain or sensory loss in groin region and genital region. Okay, next one. Next nerve will be, we are going to discuss about genitofemoral nerve. It's gives rise from L1 to L2. In motor innervation will be like cremaster muscle like genital branch. Okay, in sensation mostly we can see scrotum and labia majora, upper anterior thigh. Like in injury causes like laparoscopic surgery or trocar trauma, when we are inserting the trocar, that time that this nerve can get injury because it's very close to umbilicus and many things. Okay, in presentation we can see loss of cremasteric reflex and sensory loss below the inguinal ligament like femoral triangle area. Next one, lateral femoral cutaneous nerve. That nerve is originating from like L2 to L3, and here we can see that sensory loss like lateral and anterior thigh. And injury causes we can see like tight belts, if any patient wearing tight belts, or pregnancy, or in obesity patient, or pelvic surgeries, that time we can see that patient, because of this wearing tight belts, that now will get compression. Because of that compression we can see like lateral loss of sensation in lateral and anterior thigh. Okay, this condition we called mostly like meralgia and paresthetica. In presentation we can see like the patient will presented with burning and numbness over the lateral thigh. Okay, next one, obturator nerve. In obturator nerve, that is obturator nerve originating from L2 to L4, and its motor function will be adductor muscles of the thigh. And in sensory we can see like the sensation will get from like that are innervating in sensory in like medial thigh. The injury causes like pelvic surgery and labor. In presentation we can say like weak adduction or sensory loss in medial thigh. We can see this image, this is the area of the medial thigh. This area will get patient will loss of sensation. Okay, and weakness of thigh adduction. Okay, so next one, femoral nerve. This is femoral nerve is very important because from L2 and L3 and L4, this L2 and L3 L4, you can see here lateral femoral cutaneous nerve and femoral nerve. This femoral nerve will originates and it will go down at it, and it will, that muscle, that nerve will innervates the quadriceps, iliacus and sartorius and pectineus muscle. You can see here, this is the femoral nerve. This femoral nerve is innervating to sartorius muscle, and another one iliacus muscle, and another one sartorius and pectineus muscle. In sensory, in sensation we can see like anterior thigh and medial leg, we are saphenous branch, and we can see like some injury. This is the saphenous nerve, and this is the saphenous branch, because with this branch we can see that patient will get innervation in anterior sensation in anterior thigh and medial leg, and we can see like injury causes like pelvic fractures and retroperitoneal hematoma. If any patient got pelvic fracture, the patient is very prone to get this femoral nerve injury. Okay, in presentation we can see like weakness in knee extension, decreased patellar reflex, and sensory loss in anterior thigh and medial leg. Okay, next one, in sacral plexus. In sacral plexus we can see, in sacral plexus we already studied about lumbosacral trunk L4 to L5 and joints lumbar to sacral plexus and critical bridge for sciatica and gluteal nerves. Okay, next one we can see here, where it is, yeah, the quadriceps femoris muscle will made by 4 muscles, that is rectus femoris muscle, vastus lateralis muscle, vastus intermedius muscle, vastus medius muscle. These 4 muscles will form quadriceps. Okay, if you are seeing here, this is the this is a saphenous nerve and this one femoral nerve. Okay, so now here if you are seeing this image, you can see here L4 to L4 and S1. I don't have one good image here. Okay, L4 to S1 we can see that originates from like superior gluteal nerve. The superior gluteal nerve is main function is motor, it will like motor innervation will be like gluteus medius and gluteus minimus and tensor fasciae lata. Injury, this mostly if any person doing injections in the medial gluteal region, then that patient will get superior gluteal nerve injury. And here we can see, some Trendelenburg gait. Okay, next one, inferior gluteal nerve. In inferior gluteal nerve we can see here the it's innervating like it's originating from L5, S1, S2, and the motor will be like gluteus maximus, and injury will be like hip dislocation and posterior gluteal injections. The patient will get inferior gluteal nerve will get injury. In presentation we can see like difficulty like rising from a seated position and climbing stairs. Okay, next one, main important nerve, that is sciatica nerve. In the sciatica nerve mostly like we can see like L5 and L5 to S3, L5, L4, L5, S1, S2, S3. The motor innervation will be like hamstrings and all muscles below the knee, and it splits into like tibial nerve and common fibular nerve. Tibial nerve mostly we can see like posterior leg innervation and plantar foot. In common fibular nerve will be like anterior and lateral leg and dorsum of the foot. Injury will be like posterior hip dislocation and intramuscular injections. In presentation, foot drop, sensory loss over leg and foot. Okay, so let's connect this anatomy to real world practice. Know where each nerve runs during surgeries and injections to avoid iatrogenic injury, and use sensory and motor symptoms to localize the nerve lesions. And if any patient getting like Trendelenburg sign, then we have to think about superior gluteal nerve injury, and absent of cremasteric reflex, then we have to think about genitofemoral nerve damage. Okay, so we already discussed about this obturator nerve. In obturator nerve, here mostly we can see like its innervates like supplies the medial compartments of the thigh like gracilis, adductor longus, adductor brevis, and anterior part of the adductor magnus. In functions we can see like thigh adduction. In sensory we can see like medial thigh skin. Okay, in clinical correlation, like injury happens because pelvic surgeries. In pelvic surgeries like mostly example like lymph node dissection or gynecologic procedures, that time that this nerve can get damage, injury. Okay, and presentation will be like weak adduction of the thigh or medial thigh numbness and tingling sensation. This type of things we can see. I already mentioned here, this part will get loss of sensation. Okay, next, now we are going to discuss little deep we are going to go little now we are going to discuss little deep in femoral nerve. This femoral nerve is mostly origins from ventral rami. It originates from ventral rami like L2, L3 and L4, and mostly that this descends through the psoas major, and it emerges between psoas major and iliacus muscle, and this passes under the inguinal ligament to enter the anterior thigh. Okay, in innervation motor we can see like anterior thigh muscles like quadriceps femoris, sartorius and pectineus like partially, and function will be like thigh flexion at hip and leg extension at knee. In sensory like anterior thigh, medial leg via the saphenous nerve. Okay, if in femoral nerve we will do some in clinical main things we can use like femoral nerve block for like inguinal crias or lateral to femoral artery, and sometimes we will use for anesthesia like anterior thigh and femur knee and saphenous nerve for medial leg. Okay, so in clinical correlation this femoral nerve will get an injury like causes will be like a pelvic fracture and masses in the iliopsoas region, or retroperitoneal hematoma or abscess presentation, weakness in thigh flexion like iliacus, pectineus and sartorius muscle weakness, or weakness in knee extension because of quadriceps, patellar reflex like because of patellar reflex diminished, or sensory loss in anterior thigh and medial leg. Patients may report knee buckling or difficulty climbing stairs. Okay, so for these things how we can do diagnosis? We can do like for if you are suspecting about hematoma, that time we have to do like CT scan with retroperitoneal hematoma anterior to psoas, and we have to point at femoral nerve path adjacent to psoas, and we have to emphasize how bleeding compresses the nerve like femoral mononeuropathy. Okay, now I am going to compare the obturated nerve and femoral nerve. Obturated nerve route will be like L2, L3, L4 route, and motor will be like medial thigh adductors. In sensory will be like medial thigh. The injury cause will be like pelvic surgery. In clinical signs we can see like weak adduction and loss of sensation in medial thigh. Okay, in femoral nerve that route will be like L2, L3 and L4, and same to same like obturated nerve. In motor will be like anterior thigh. Okay, like flexors and extensors muscles. In sensory we can see like anterior thigh and medial leg saphenous nerve, and injury will be like injury cause will be like pelvic fractures and hematoma, and clinical signs will be like a weak adduction, clinical signs will be like femoral nerve will be like knee buckling and decreasing patellar reflex. Okay, so here now I am going to ask some questions. So we discussed everything about this lower lumbosacral plexus and lower extremities nerves. So I will ask some 3 questions. So with these 3 questions you have to give me reply in comment section. Okay, first question will be what nerve is responsible for thigh adduction. Second question, I am repeating first question another time, what nerve is responsible for thigh adduction. Second question will be what sensory area does the saphenous nerve cover. I am repeating again, what sensory area does the saphenous nerve covers. Third question will be which nerve runs beneath the inguinal ligament. I am repeating another time, third question, which nerve runs beneath the inguinal ligament. So in clinical application in surgery, trauma or radiology always trace nerve anatomy in relation to muscles, ligaments and vessels. Okay, so this thing will help to prevent iatrogenic damage while doing surgeries and everything. So if you think this video is very valuable for you, so please like, share and subscribe. We will meet in our next video. Take care. Bye bye.